today, this is just a little bit about what we're going to go through and hopefully cover. We're certainly going to cover an overview of obsessive compulsive disorder. We're going to talk about evidence-based treatments for OCD, and we'll talk about how you implement and what evidence-based treatments for OCD might look like in practice. We'll also touch briefly on related disorders, just kind of going through a little bit of overlap, but this presentation will focus majority on OCD specifically. So what is obsessive compulsive disorder? I think so many people in today's world really have a lot of different stereotypes, understandings, perceptions of OCD, and unfortunately a lot of those stereotypes and perceptions are not accurate. So what we're going to do through today's presentation is hopefully be able to take away what isn't true and have you leave with a real understanding of what the disorder is and the disabling nature of obsessive compulsive disorder. So what we know is that OCD is a neurobiological disorder characterized by two items. This is important because a lot of people can have obsessions, a lot of people can have compulsions or rituals. Doesn't necessarily mean they have OCD. In order for someone to get a diagnosis of OCD, we really need to see both. We need to see obsessions, which are characterized by recurrent, unwanted, or unpleasant thoughts or images. The key word here that I really want you to hone in on is that unwanted and unpleasant. These aren't thoughts that people enjoy. These aren't thoughts that someone gets pleasure from. These are thoughts that they really don't like, they would do anything to get rid of, yet they continue to pop in their mind. In order to often get rid of or subsidize the anxiety that comes along with these unwanted intrusive thoughts, individuals engage in repetitive ritualistic behaviors. So these are known as compulsions. So again, when we think about what is OCD, we need to think about what makes up the disorder, and it's two things. The first are these recurrent, unwanted, intrusive thoughts, and the second are those repetitive rituals or compulsions that someone engages in. Just to go back or kind of keep talking before we move into specific diagnostic criteria, I do want to touch base just for a second on what kind of the public tends to think OCD is. So when you think of OCD or you ask somebody who maybe isn't in the mental health field, what is obsessive compulsive disorder? What we'll often hear is people saying things like, oh, someone who's afraid of germs, or, oh, I have a coworker that's so OCD, you should see their desk, or my aunt is so OCD, if we move anything in her house, she knows we've touched and moved it, even if we only move the object over a few inches. The reality is that that's not necessarily OCD. Just because somebody keeps their fridge super organized or somebody spends a lot of time double checking and, going through an assignment that's due because it's a big project, that doesn't mean someone was OCD. OCD is not an adjective. Someone is not so OCD. Instead, it's a chronic, debilitating, disabling mental illness. OCD is something that individuals with the disorder would do anything to get rid of. It's not a disorder that makes you feel better or that makes you feel good about about your rituals that you did. The reason this is important to note is that when someone talks about, let's just say somebody who organizes their fridge in a certain way and likes all the labels pointing in a certain direction, or somebody whose closet needs to have all their shirts in a certain order and color coded, that doesn't necessarily mean it's OCD. What I mean by that is that may be more OCPD, which is obsessive compulsive personality disorder, which we may spend a few minutes at the end of this presentation talking about. But there's a difference between something that someone does because they get pleasure out of the end result. So they organize or they do things in a certain way, but they feel good at the end. They feel accomplished, or they feel like things are now organized, or, they get some sort of joy or good feeling out of it. That's not OCD. OCD are these unwanted intrusive thoughts, and someone feels compelled to perform the rituals, and the only good feeling they get is a little bit of reduction in their anxiety until that next thought comes along. But overall, they don't feel accomplished, they don't enjoy the activities, they don't at the end say, wow, I'm really glad I did that. Instead, they're saying, why do I have this disorder, and I would do anything to not have these intrusive thoughts and have to do these rituals. So there's a big difference in the two, and I just want you to keep that in mind. I also want you to think about the chronic disabling nature of OCD. OCD is one of the top 10 reasons people file for disability in the United States of America. OCD affects roughly 3% of the population. OCD is a chronic and debilitating illness. It's not something to poke fun of or make light of like often society or the media does. So we need to really start to understand what obsessive compulsive disorder is and the devastation that it causes on individuals and family members of those affected with the illness. I'm not going to spend a lot of time going through DSM-5 diagnostic criteria because you certainly can pull out a DSM-5 to look this up yourself, but I just want us to kind of talk about the main components of what makes up an OCD diagnosis. So as we know, the first component is that there needs to be the presence of obsessions, compulsions, or both. Obsessions are defined by both 1 and 2 here, which is 1 are those recurrent and persistent thoughts, urges, or images. The second is the individual attempts to ignore or suppress these thoughts, urges, or images, or to neutralize them with some other thought or action. This is often what we know as the compulsion. Compulsions are defined as repetitive behaviors, so these can be hand washing, counting, etc., or mental acts that the individual feels driven to perform. They can also be, the behaviors or mental acts are often aimed at preventing or reducing anxiety or distress or preventing some sort of dreaded event or situation. The obsessions or compulsions should be time-consuming. So this is often marked by more than an hour a day, and they should cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. The OCD symptoms should not be attributable to the psychological effects of a substance, so drug abuse or medication or another medical condition, and the disturbance shouldn't be better explained by another mental disorder. So comorbid or kind of often mental disorders that tend to take on a lot of OCD characteristics that make it misdiagnosed might be GAD, generalized anxiety disorder, body dysmorphic disorder, hoarding, trichotillomania, and disorders of the like. It's important to specify if the individual has good or fair insight, poor insight, or with absent insight or delusional beliefs, and then of course to specify if tic related. So again, I spoke a little bit about this earlier, but OCD is a mental illness that's characterized by unwanted intrusive thoughts and followed by repetitive rituals or compulsions. We used to often hear what we call pure O OCD, where individuals, we assumed or thought that individuals really just had that obsession component and not compulsion. We've kind of strayed away from that a little bit because what we find is that individuals are typically engaging in some type of ritual, although it may be not an outward ritual. So what I mean by that is that somebody who has an unwanted intrusive thought, if they're not engaging in an outward compulsion like checking or hand washing or reassurance seeking or something of the sort, they may be engaging in mental rituals. So you might say, what's an example of mental rituals? Mental rituals can include prayers. Sometimes individuals have a certain color or number that's a safe kind of color or number that they might mentally envision that. Maybe they play back through their mind kind of the whole scenario in a way to get their own self-reassurance, that sort of thing. So we do believe that most individuals with OCD experience both obsessions and compulsions of some sort, even if those are mental compulsions. Again, OCD affects about 2 to 3% of the population, and every facet of quality of life is significantly influenced. I talked a little bit about some statistics earlier, and the reason I think those are important to share is I think a lot of us don't understand the devastating nature that OCD has on individuals and family members, and it's important for us to know that so that when we're working with clients, we can help them understand they're not alone, and we can empathize with some of the feelings and frustrations and difficulties that they're experiencing. So now that when we kind of go into what are some common forms or specific subtypes of obsessive compulsive disorder. So when you think of OCD, I want you to kind of think of a large umbrella, and underneath that umbrella, there's multiple different categories that attest to individuals' symptoms. So the first category, and the one that I list first because it's often the one individuals think of when they think of OCD, is contamination. So contamination is often individuals have a fear of germs, disease, poison. This can be contaminants. It could be airborne contaminants. There's all sorts of things that can fall under the realm of contamination. When we think of checking, we often think of individuals who get stuck checking appliances to make sure they're turned off, or checking doors to make sure they locked them, or going back and checking over and over in order to get that kind of sense of relief or that anxiety reduction because of a feared outcome that they're afraid is going to happen if they don't go back and check. Scrupulosity. Scrupulosity is the religious form of OCD. This type of OCD really is centered around moral and religious kind of, maybe it's rooted in moral and religious beliefs, but it takes on its own form and it takes on OCD where it's no longer a healthy kind of relationship or religion. Instead, the OCD has taken control of individuals' thoughts and feelings surrounding morals. And so what we often see with scrupulosity may be like excessive praying or excessive reassurance seeking, or even visiting, the church and getting reassurance from church members that they hadn't done something wrong, that kind of blasphemous thoughts and feeling like they need to do something, maybe prayers in a certain way. So these ritualistic prayers where they have to pray a certain pattern or say things a certain number of times, or even number issues can be around scrupulosity. So that fear of the devil and 666 may cause someone with OCD to have lots of fears of that number, multiples of that number, dividends of that number, all because of this scrupulosity-based obsession. Perfectionism, where individuals get stuck feeling like things need to be perfect or just right. There's kind of an overlap between perfectionism, or there could be an overlap between perfectionism and just right OCD, but we might hear about individuals spending an extreme amount of time perfecting their signature, or spending a lot of time writing and erasing and rewriting homework or documents until it feels like it's done perfectly or done the right way. Just right OCD is often the type of OCD when we hear individuals say things like, I just have to keep doing this ritual until it feels right. Often that just right feeling might be when there might not be a certain set of rules or numbers that they're getting to, but it's just until it feels right. Often we know that kind of right feeling is when there's a reduction in anxiety. So we'll hear this a lot with young kids who maybe get stuck putting their socks on and off, or, not able to just do something once or wear a certain, clothing item and having to put it on and off until it feels just right. And this often can be until they feel a reduction in their anxiety or they feel okay. Somatic OCD often surrounds that kind of almost hypochondriasis, right? So these feelings or sensations in your body, maybe medical related, maybe fear of illnesses, that sort of thing, where you start to feel different things in your body and you start to question it and wonder what's going on. Often we know that if you're scanning your body 24 hours a day, we can all kind of notice or feel different symptoms or different things that are going on. So with OCD, it's often surrounding these intrusive thoughts. And so these intrusive thoughts might be, I got a disease, or I was exposed to something, or what if I picked something up, that sort of thing. And then the somatic kind of umbrella falls under that, fear of health and body kind of related issues. Violent intrusive thoughts and sexual intrusive thoughts, in my mind, are two of the most stigmatized forms of OCD, yet they're two of the most common as well. So these are individuals who experience intrusive violent thoughts or intrusive sexual thoughts. Again, these are unwanted intrusive thoughts. These are not individuals who experience a violent or sexual thought and it's a fantasy or it's something they're enjoying or something they want to act out on. These are violent and sexual intrusive thoughts that individuals would do anything to get rid of, yet they can't. They can't seem to get rid of this horrible intrusive thought, and the only way they find relief is by performing a ritual, whether that's reassurance seeking or looking something up on the internet to make sure they didn't do something wrong, whatever it might be. These are unwanted intrusive thoughts. These are not individuals who would act on these violent intrusive or sexual intrusive thoughts or engage in any sort of wrong activity around them. Instead, it's these horrible intrusive thoughts that, why would I think this? Why do I have that thought? Now I have to get rid of it. And so not only is there rituals often attached, but there's also a large amount of guilt that's often attached to these sort of thoughts because they tend to go against people's moral beliefs to the extreme, right? It's the opposite of who they are, the opposite of the type of things they would want to engage in. And so they have a lot of difficulty not only with dealing with these and talking about them, but additionally there's that stigma attached, right? When you suffer with contamination OCD where you're engaging in a lot of hand washing, the stigma, it's still there. It's still strong when you live with any mental illness, but it's different when you feel like you're going to go talk to somebody about something that you feel like, oh, they probably hear this a lot, or, this is a really common form of OCD. Well, because sexual and violent intrusive thoughts are often not talked about and people are scared of them, there becomes this additional layer of stigma and anxiety and fear of what are people going to think of me? They're going to think I want to I would actually do these things or that I get pleasure out of these thoughts. They're going to think I'm this horrible person, right? All these additional layers that tend to come along with this than just a traditional maybe obsession or compulsion that's based around checking or contamination. I listed primary, primary care, faith-based institutions, and mental health clinics here. These are often the first line of treatment. So this is often one of the first places that individuals will go when they're struggling with OCD or any type of mental illness. But unfortunately, these are often also the places that misdiagnose or don't know what's going on or don't know how to refer to proper treatment. So I'm so excited that you're spending the time to watch this presentation and hopefully learn about OCD and learn about the effective treatment for OCD, because even if you can't perform that because you don't know how, you can refer out, but you'll know the right questions to ask. You'll know how to know if somebody really understands the disorder and can help your client or not, versus not being able to tell them and give them appropriate help and hope for their diagnosis. So what are some common obsessions? I'm not going to go through all of these because this PowerPoint you can continue to go through and look at on your own. I'll tell you at the end of this presentation how you can get access to the PowerPoint for free should you want to use it, or be able to access it after this presentation. But these are some common obsessions. So fears that scary or harmful things are going to happen, thoughts about losing control or becoming aggressive, persistent and unwanted sexual images, fixation that you're doomed, unwanted blasphemous thoughts, mental rearrangements of letters and words, fixation on a number or letter, need for order and symmetry, concern that your actions might endanger someone else's safety, worrying about germs or getting sick or doing something wrong. Some common compulsions, so checking and rechecking continually, arranging and lining up items in a straight line, that could be around symmetry based, engaging in washing and cleaning rituals, counting until you reach a magic number, touching things in a ritualistic fashion, moving and rearranging objects in certain patterns, going in and out of doorways until something feels just right or until there's a reduction in anxiety. We can see this can happen for all sorts of different types of OCD, not only just right OCD. Can also happen for scrupulosity, where an individual, if they're going through a doorway or a threshold and they have a bad thought, they may continue to go back and forth saying a prayer or until they have a thought that seems okay, because of the fear that if they don't, something bad might happen and it would be their fault. Asking questions repeatedly, this is also known as reassurance seeking, erasing excessively, and then also hoarding and saving unnecessary items. I think it's important for us to have the hoarding and saving of unnecessary items last so that we can spend a second to talk about it. It's important to distinguish between hoarding for OCD and hoarding disorder, and there is a difference between the two. Let me give you an example. Somebody who is a hoarder may hoard, or often is hoarding all sorts of items, so items that don't necessarily have use, and these items are taking up living spaces such as kitchen, your stove, not just an organized collector. This isn't just somebody who has things in their storage or has things in their basement. These are individuals who the clutter and the unnecessary items have taken over their living space, and there isn't necessarily a reason they're keeping them except the thought that they may need them in the future. With OCD, you can see OCD hoarding in different manners, but an example of one might be when it's based on scrupulosity. So the individual is really doing a scrupulosity ritual versus hoarding. And an example of that might be when somebody attends church, right, and they're given a church bulletin, keeping all those church bulletins, and not because they want to keep them and they think there might be use for them, but instead the fear might be, if I throw out this church bulletin, God might be upset with me and something bad might happen, or I might not go to heaven, or my family might not go to heaven, and it would be my fault because I didn't save that bulletin, or because I threw it away, and throwing it away maybe showed or meant that it wasn't important to me. And so that is the difference between maybe someone hoarding small objects based on their OCD versus someone hoarding objects because of hoarding disorder. What are some things you might notice of somebody with obsessive compulsive disorder? So you might notice excessive reassurance seeking, so frequently asking questions to their mom, their teacher, their coworker, their spouse, their significant other, their friends about I did something, is this okay? Or does this mean I'm a bad person? Or do you think something bad might happen because I had that thought? So these are not normal questions like sitting down and talking about finances together. These are questions that seem out of the ordinary, don't seem to make sense, but the individual is needing specific reassurance or specific answer in order to feel better or feel okay. Frequent requests to use the bathroom or staying long there. This may be a sign that individuals are engaging in some contamination or some type of OCD behaviors and that they may be getting stuck in there, stuck in the middle of their rituals. Excessive hand washing. This may be noticeable because you might see individuals with chapped or cracked or bleeding hands, maybe even sometimes all the way up to their elbows, and it may be a sign that they're spending a long time washing and scrubbing. Rearranging of items until it feels just right. Repetition of other activities until the individual feels it's done just right. Needing to start over if interrupted. So this can be both in actions or in conversations, but especially if someone's asking reassurance or engaging in an OCD ritual, if somebody interrupts them or something happens that they have to stop in the middle, they may start over at the beginning to know that they did the ritual or asked the reassurance correctly or in the right way. Difficulty changing tasks or fixating on one task, repetition of action, sounds, words, or music, and then, of course, inability to finish work. This may specifically be when we're talking about school tasks or work tasks, even though the individual has the ability to do so. So we're not talking about individuals who aren't capable of doing the work or they didn't study or they don't know the answers, but we're talking about when they know the answers, but you find that they're having difficulty turning in assignments and you might start to say what's going on. And maybe when you explore, it's because they spent hours writing and rewriting or they got stuck reading and rereading on the book in their textbook and they just didn't feel like they could complete the assignment even after hours of work put in. It's much different than somebody who didn't spend any hours or any minutes of work and just didn't complete the assignment. So there's definitely a difference between the two. What's important when we talk about noticeable obsessions, compulsions, and symptoms, or things you might notice of someone with OCD, is that just because somebody has one or two or these seem recognizable to you doesn't mean the individual has obsessive compulsive disorder, right? So again, we need to go back to that beginning of what is OCD when we talk about it's the combination of an unwanted intrusive thought known as an obsession and repetitive behaviors known as rituals or also known as compulsions. Those two things together are what makes up OCD. So someone has an obsession, they engage in a ritual to get rid of that obsession because of a fear, a deep-rooted fear that's there, and then they feel a little bit better. That happens temporarily, and then they have another obsession, they engage in another compulsion to get rid of that anxiety that the obsession brought, and the cycle continues. There are individuals with other diagnoses. So when you think of autism and you think of certain, even Tourette's, right? There's certain illnesses that somebody can have that some of these things might make sense, right? So that need for lining things up or symmetry or repetition of action, sounds, words, or music, right? That may not necessarily be OCD. So we need to be cognizant and able to diagnose correctly because treatment is certainly going to differ. So OCD may interfere with someone's ability to concentrate, their ability to complete assignments with reading and writing. It often obstructs changing activities, so we find OCD may be kind of heightened or triggered when individuals need to change. So this might be like when they're in school age and they start having to switch classes and they have a locker, or when individuals are at work and they're asked to move desks, or they're asked to kind of go to another assignment, or sometimes change can be difficult because of the anxiety and the fears that surround that. OCD may call unwanted attention to the child or adult, and it, of course, often interferes with all sorts of social, occupational activities. OCD tends to wax and wane over time. The disorder often changes in both frequency and type. It's heightened under stress, and it often can be influenced by coexisting conditions. This is important because when we think about OCD in individuals, seeking treatment, this often is one of the things that people get the most confused about or family members struggle the most with. They'll say something like, well, last week she was so worried about fear of bloodborne illnesses and her contamination was so strong, but this week she's saying that doesn't even bother her anymore. She's not even afraid of those things, and now she's worried about that she's going to start the house on fire if she doesn't turn the appliances off and check them all. That's confusing to us, and it makes us feel like she's making it up. The reality is that she's probably not making it up. But it is confusing. It's very confusing from the outside to say, well, how come last week you were worried about this, but this week you're worried about that, and now the other thing doesn't make sense. It feels like when we start to work on one thing, therapists can struggle because they'll say things like, well, as soon as we start working on one thing, another thing pops up. And so it can feel confusing. It can feel frustrating to individuals. But what I can tell you is that that's a common characteristic of the disorder. Often, whatever an individual is triggered by the most at that time or that week, that's what their OCD often grabs a hold of. That's why we see OCDs often heightened under stress, transition, difficulties. It's just like with any illness. When we're more vulnerable, right? Maybe we're sick, or we haven't had a lot of sleep, or we're moving houses, or we're in the middle of a high stress situation. We're more vulnerable to our OCD taking control and having difficulty being able to manage the things that maybe we could manage before because we have all these additional things going on. So again, just keep in mind that these are characteristics of the disorder, and it's normal for the symptoms and the symptomology and the types of someone's OCD to wax and wane with time and to change in frequency and type. And so although this can be frustrating as a parent or a friend or even a professional treating the individual with OCD, it's important to know that that's a common characteristic of the illness. That's also, I will say, one of the things that makes it difficult for people living with OCD. It's hard for individuals to spend so much time and effort into the treatment that it takes, only to say, okay, well, I spent all this time and effort to work on contamination, and now it's something else. And so am I going to work on this thing and then something else is just going to pop up? Because if so, why is this worth it? Why should I even do all this hard work and treatment if I'm just going to continue to have new triggers and new things I face? The reality is that new things can pop up. And as we work on one OCD area, another area may come on, and that area may come on stronger. It doesn't mean, though, that you shouldn't try and we shouldn't fight. What it means is that let's keep fighting and let's continue to fight that OCD so that it isn't interfering with your life or doesn't have control over your life more than you do. And what we'll find is that the better you get at using the correct tools to fight your OCD, when new things come up, you can easily adapt and use those new tools that are right there in your backpack so that new area that's causing difficulty doesn't take over the way the last area did. These are some myths about individuals with OCD. So, I think hopefully I'm not going to have to go through justifying individuals who have OCD are crazy, that's a myth. But the reality is that sometimes it does seem bizarre, right? It seems especially confusing to people when someone with OCD makes comments like, I know what I'm doing doesn't make sense. I know that this isn't rational. I know that I can't really get a disease if I touch that doorknob, but I just have this weird feeling that if I don't wash my hands, I don't feel better. That can be confusing to the outside. Well, why, if you know you don't need to do it, why are you still doing it? Because their illness is telling them to, right? If they could resist the rituals on their own, I promise they probably would. These rituals aren't fun. They're often embarrassing. They're difficult. They're frustrating. And so we would do anything to not have to engage in them. But we often feel like if we don't, there's this bad outcome, right? Something bad's going to happen to someone we love or a family member. And so that kind of overweighs that frustrating, annoying part of the rituals. Individuals can stop what they're doing. In a sense, yes. I mean, no one is forcing us to do these rituals, but what's driving us is this horrible anxiety and these awful feelings that are laced with fear and frustration and doom. And so you feel like, okay, what's the alternative? If I don't do this ritual, I might cause something bad to happen. Well, I might as well just do this ritual and get it over with. And so it's this catch-22. But what I will tell you is that individuals who are showing you're able to see their rituals and they're struggling in front of you or they're talking to you about it, if they could stop on their own. So if it didn't cause them a significant amount of anxiety and distress to where they could, not do these rituals and still feel decently okay, I promise you they would. Nobody with OCD wakes up and wants to do their rituals and does them for attention or some sort of other motivating factor. We do them because we have this fear that if we don't, a horrible outcome will happen and we have difficulty living with that uncertainty and anxiety that surrounds that. All children who follow rituals have OCD. Again, we talked about this a second ago, but that's not necessarily true, right? Individuals with autism and other disorders, we see them following rituals and engaging in ritualistic behaviors and patterns, but it doesn't mean they have OCD. All OCD needs treatment with medication and therapy. Not necessarily true. Although medication and therapy is often the most effective and what we find to be the most widely used treatment for OCD, individuals can engage in only therapy and receive amazing benefits. And often individuals who use both may want to taper off medication one day, and that's fine. If it's one or the other, they do always need therapy. So we always choose therapy over medication, because medication alone is not going to treat the OCD in its entirety. And OCD is not a curable condition. Unfortunately, there's just not enough research, not enough funds behind obsessive compulsive disorder, but it certainly is a manageable condition. And so I always equate it much to that of diabetes. Some days are worse, some days are better, but with proper management and care, and the more you learn how to effectively manage and understand your own illness, the better prognosis you'll have. So let's talk a little bit specifically about what OCD looks like and how the OCD cycle works. I want you to look at the bottom left corner of this triangle, and let's talk for a second about an obsession. So an obsession is often that trigger, what drives someone's kind of first ritual and, kind of starts this OCD cycle or this OCD pattern. An example of an obsession might be something like, somebody goes to leave work, and when they go to leave work, they have to touch a doorknob, and so they have this intrusive thought that, what if somebody before me touched the doorknob had a bloodborne illness, and what if they had a cut on their hand when they touched this doorknob, and I touched this doorknob? What if I have a cut on my hand, or I might come in contact with that blood, or I might touch my eyes after, and so maybe that blood is going to contaminate me, and I'll pick up a disease, and then I'm going to give it to a family member or a friend. That's just an example of one obsession. So the compulsion is, after I touch this doorknob, to wash my hands. And as soon as I wash my hands, I feel better. I feel this immediate relief. I feel this weight off my shoulders, and I just feel better. And I'm not anxious anymore. I'm not worried about the disease. But if I don't do the compulsion, that anxiety might linger. I might continue to have more fears. I might be afraid to go in my car and touch different things, or touch my keys, or touch my phone. But if I do the compulsion, I feel better. Now I can engage in my normal activities. But what happens is that, oh my gosh, I feel better, that relief is temporary. That's not permanent. Somebody with OCD doesn't do one ritual and feel better for the rest of the day. They do one ritual and then they feel better, they feel a sense of relief, and before you know it, another obsession comes, and then they're engaging in another ritual, and then that happens again and again. And that time period of relief, that temporary relief, might go from a 30, 40-hour window to a 5, 2-minute window before the next obsession comes and the next ritual is being engaged in. So what happens is, as individuals with OCD continue to have obsessions, if they continue to do compulsions, they're feeding that cycle. And it will become a cycle of obsession, compulsion, temporary relief, obsession, compulsion, temporary relief. In order for us to help them manage their OCD, we've got to break that cycle. So what works? What works for us to treat individuals with OCD? What we know works is a specific type of cognitive behavioral therapy known as exposure with response prevention, also known as ERP. I will refer to exposure with response prevention as ERP throughout the rest of this presentation, just for time and so that it's not as lengthy of a response as we continuously talk about it. We'll talk in a second about what ERP looks like, how it might be done in therapy, and some of the results. There's also, of course, pharmacological interventions, so SSRIs, TCA, and SNRIs are often used for OCD treatment. Because I'm not a psychiatrist and, this isn't my area of expertise, I'm not going to spend a lot of time going into pharmacological interventions for OCD, but there is a link here that you can visit. So the International OCD Foundation has lots of information and resources about medication for OCD. There's multiple treatment options when we talk about what type of treatment can someone with OCD engage in. So there is, this, if you look at this kind of list, it goes from probably most severe OCD to least severe in the sense of the different types of treatment that might be recommended. But we start with an option which is inpatient or residential treatment. There's really only 3 residential treatment, inpatient/residential treatment centers across the United States that are specific OCD treatment centers. The first and kind of the granddad of them all is at McLean Hospital, which is attached to Harvard Medical School. And this is the OCDI. So this is the Obsessive Compulsive Disorder Institute. It's run and headed up by Dr. Michael Janicki and Diane Davy. This clinic is kind of where the rest fall under. And what I mean by that is that most of the other clinics are headed by somebody who has trained or did an internship or training under Dr. Michael Janicki. And so the OCDI is often the home base for OCD treatment. The second is Rogers Memorial Rogers Memorial Hospital, which is in both Wisconsin, Oconomowoc, Wisconsin, which is about 45 minutes outside of Milwaukee, and now they have a clinic in Tampa, Florida. The Rogers Memorial is headed by Dr. Brad Riemann, who also did his training under Dr. Michael Janicki. And then the third is the Houston OCD program, which is headed by Dr. Thruster Bjorvensen, who works both in Houston and at McLean in Boston, Massachusetts, also did training under Dr. Michael Janicki. There's multiple options for outpatient treatment across the United States. Individuals can engage in different types of outpatient therapy. So they can do intensive outpatient treatment, which may be 3-day-a-week treatment, or they can do, typical outpatient. So that might look like, once a week an hour session, or maybe once every other week an hour session. There's also support groups available as a treatment option for obsessive compulsive disorder. And then there's, of course, self-help options for OCD. So self-help might include self-help websites, which are available for individuals with OCD. There are self-help workbooks available for individuals with OCD, and lots of self-help books as well for people to be able to access for OCD care. There's a couple different assessments that are used when we're trying to understand and look at someone's OCD, understand the severity, which can help us best refer them to appropriate treatment. The first and the most well-known is the Yale-Brown Obsessive Compulsive Scale, also known as the Y-BOX. The Y-BOX is a 10-item measure which looks at both obsessions and compulsions. So the Y-BOX asks 5 questions about obsessions, 5 questions about compulsions. Each question has a Likert scale rating of 0 to 4, and so the total score for the Y-BOX can range from a 0 to 40. And at the bottom of the Y-BOX, you'll see a scoring rubrics. This rubrics allows you to put individuals in categories of mild, moderate, severe, or extreme OCD. And so it helps us to understand in a pretty quick measure what type of OCD someone might have. So how much are they struggling? How severe is their illness? Which may inform us to make better practice decisions for referrals or for specific treatment for that individual. The Dimensional Obsessive Compulsive Scale, also known as the DOCS, is a new scale derived by Jonathan Abramowitz. Dr. Abramowitz is out of UNC. This scale's gotten a lot of leadway, so it's an amazing scale because it measures specific OCD categories. So instead of just measuring overall kind of how much time does your OCD take, how much interference does your OCD have in your life, the DOCS looks specifically at contamination, specifically at perfectionism, that sort of thing. So it looks specifically at different categories. And so it's a great scale for you to be able to ask and understand what specific types of OCD your client is dealing with. There is also some supplemental scales for the DOCS, which include violent intrusive thoughts, sexual intrusive thoughts, and there's another one. And so those supplemental scales can be used in addition so that you can really cover all categories when you're using the dimensional OCD scale. So what is ERP? Well, ERP is exposure with response prevention, and it's essentially exactly what it sounds like. The goal of exposure with response prevention, just like exposure therapy for lots of other individuals with anxiety disorders, is to expose these individuals to their fear. The difference between ERP and traditional exposure therapy for other anxiety disorders is that it has this response prevention component. And what that means is that individuals need to prevent ritualizing. So somebody with OCD does exposures on a daily basis, and this is something that a lot of people don't understand at first, but I think it's very important and critical that we help you understand. Somebody with OCD, like we used that scenario earlier, when they need to leave their office and they have to touch that doorknob, but they're overcome with anxiety about touching their doorknob. They have a couple options. They can either A, avoid touching the doorknob. They can wait until another, coworker comes and opens the door. They could pretend like they're on their cell phone, whatever it might be, but wait for someone else to touch the doorknob so they don't have to. They could use a barrier, so they could use a sweatshirt or a paper towel or a Kleenex that they see nearby to touch the doorknob so that, again, they don't have to and they can throw that barrier they used away after. Or they can touch the doorknob because they need to get out and they have to touch the doorknob to get out of the office. If they touch the doorknob, yes, they've done an exposure, which is a great first step. However, if they go straight to the restroom after touching the doorknob that's in the parking garage or that it's on their way to their parking garage and they wash their hands before they get in their car, they have not done anything to help their OCD. In turn, we've reinforced that OCD cycle. But instead, if they do that exposure and they don't wash their hands, that's how we slowly fight away at OCD and break the OCD cycle. So what happens when we do ERP is, first and foremost, we have to understand our clients' obsessions and our clients' compulsions. It's impossible for us to develop a proper hierarchy, which is what we're going to do for OCD treatment. We'll be talking about that in a second, if we don't really understand the depth and severity of someone's illness. So if somebody has contamination fears and we only know one fear, but they're really struggling with 20, we're not going to be able to properly help them in treatment. So the first step is always for us to really understand in depth our clients' obsessions and compulsions and the way they affect their life. This might be done through having individuals carry around a notebook, or nowadays they can do it on a smartphone, and for a week or two where they're tracking all of their compulsions or rituals, and after they engage in them, they're writing down what triggered that, or what the fear was, or how difficult would it be to not engage in that ritual. So again, we need to track and understand all the different rituals, all the different obsessions, so that we can properly help them. Next, our step is to create hierarchies. So a hierarchy is a list of 1 to 10 that we develop for certain fears or exposures that our clients have. So what we always ask our clients to do is to rank their exposures. So if somebody has a fear of the house catching on fire, and so they're a checker and they're having difficulty leaving and they're checking appliances, and they find that even when they're halfway to work, they're turning around and they're going back and they're checking appliances again, we might develop a hierarchy centered around this, centered around checking. So the hierarchy would be a list of 1 to 10, and 1 is at the bottom of the hierarchy. So the hierarchy would literally go 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And 1 would be an exposure that would only cause them a level 1 out of 10 on an anxiety scale. So we call this the SUDS rating, the Subjective Units of Distress Scale, where we ask individuals on a scale of 0 to 10, how difficult would this be for you? So on the lower level, the 1 or 2, it might be something like leaving the fridge plugged in. They might say, it bothers me, but I'm able to do that. That's something I could do. Where midway up that hierarchy, a level 4 or 5 might be, leaving a lamp plugged in and turned on. That might be really difficult. Where a level 10 might be leaving the house with the dryer running, right? And so together, what we do is on this hierarchy, we rank these exposures from 1 to 10, 10 being the most anxiety provoking, 1 being the least. And when we start ERP, so when we start exposure with response prevention therapy, we start at the bottom of that hierarchy. So we'll start with having them leave their fridge plugged in and leave the house. And what we'll do is we will have them continue to do that same exact exposure until it doesn't cause them any more anxiety or fears. And what we'll often hear is individuals will say things like, I think I'm doing something wrong because I'm really bored by this. That's kind of our golden ticket that, nope, that means you're doing it exactly right. So when you're bored, we're ready to move on to that next level exposure. But we shouldn't move up the hierarchy until clients have successfully completed a level on the hierarchy where they can engage in that and they're not engaging in any rituals. It's important to note that rituals can change. So what we don't want individuals to do is to do an exposure and they're not doing the ritual they used to, but now they're doing a different ritual. So maybe they're not going back and checking to see if the fridge is unplugged, but they're calling their roommate halfway through the day and just checking in on their roommate because they know, oh, well, if the house had caught on fire or something had happened, they would tell me. So that would be a ritual. So it's important that they're doing these exposures without any rituals. It's also equally, if not more important, that we always start at the lower ranking exposures and we gradually work our way up as individuals engage in successful exposures with response prevention. So without rituals. So what's a hierarchy? This is what we were just talking about, but a hierarchy is the use of the subjective units of distress scale. So that's what we call the SUDS rating, where we ask individuals, okay, if I ask you to do this, how difficult would it be? Give me a number on a scale of 0 to 10. 0 is the least anxiety provoking, also known as kind of cool as a cucumber. 10 is the most anxiety provoking, maybe where you're experiencing a panic attack. And we take these list of exposures with rankings and we develop them into a hierarchy. So again, that 1 to 3 should be lower ranking exposures, 4 to 7 should be mid-level exposures, and 8 to 10 should be high-level exposures. It's so important and critical that we systematically work our way up. So we need to start at the bottom when we've successfully worked through that and it's not causing anxiety and there's no rituals attached, we can move to the next one. What's important to note is that certain clients may have one hierarchy or they might have multiple hierarchies depending on their OCD. So when we talked about OCD subtypes earlier on and we talked about contamination and scrupulosity and just right OCD and the like, there was much more, but some individuals might just have one type of OCD, maybe just contamination, or they might have multiple types of OCD. They might be dealing with contamination, scrupulosity, harm to self fears, or violent intrusive thoughts. I would always recommend that you do a hierarchy based on the specific OCD subtype. So I wouldn't recommend one hierarchy that focuses on contamination and scrupulosity and violent intrusive thoughts. Instead, have one hierarchy for each. And so some clients, you may only have one hierarchy. If they only have one specific fear, you might have multiple. You also might have multiple hierarchies or a hierarchy that has multiple items within it for contamination. So you might not only have 10 items on the hierarchy. You might have 4 or 5 level 10s, 6 or 7 level 8s, 3 or 4 level 7s, etc. And so the hierarchies are going to be dependent on your client and their specific fears, and it's going to be up to you to be able to really assess the different types of things that cause them anxiety around that fear so that you can develop a hierarchy appropriate to them. Let's do a quick example of what a hierarchy might look like. So if we have a 23-year-old female client who has obsessions and compulsions around diseases, specifically bloodborne illnesses, her specific fear is the fear of HIV/AIDS. She's no longer touching doorknobs in public, using public restrooms, and is very anxious about her upcoming annual doctor's appointment. The fear has become so intense that she's avoided many social activities in public and is finding everyday tasks to be difficult. Her rituals anytime she's triggered by this fear is to engage in washing her hands, her body, or her clothes depending on what she touched or came in contact with. I want you in your mind to think for a second about what a hierarchy for this client might look like. What do you think some lower level exposures might be for this particular client? What might some mid-level exposures be? And what do you think the highest level exposures might be? Now, keep in mind that this is a guess for us based on this client. We have to talk specifically with the client and work together. It is never your job as a practitioner working with an OCD client to develop a hierarchy for them. Instead, it's our job to develop a hierarchy with them. Because to us, what makes sense and what should, in our mind, be a lower level or higher level exposure might be completely different for that client. So this is just an example of what it may look like. So a lower level exposure might include shaking hands, touching a doorknob, etc. And one thing to keep in mind, I think a lot of individuals kind of talk to me about this. Well, what if it's just too hard for them to touch a doorknob? Okay, well, how can we help them get there without having to actually touch the doorknob? I might ask the client, how difficult would it be if I touch the doorknob and then you shake my hand? How difficult would it be if I touch the doorknob and then I touch this book and you hold this book? So there's all sorts of ways for us to get at different exposures, but what's important is that we need to do exposures that the client is willing to engage in, and they need to be exposures that have a couple components. They need to be specific, they need to be challenging, yet they should be obtainable. There is no point in doing an exposure that's too difficult for your client if they're going to go ritualize right away. If after the exposure the client's going to ritualize, you have completely ruined the exposure process to begin with. So it's important that they understand and they're on board with the fact that it should be challenging, it should be specific, but that it should be obtainable. If they can't do it, we're going to set them up to fail. What might a mid-level exposure be for this client? Some examples of mid-level exposures might be using a public restroom or going to a doctor's appointment without asking reassurance. Maybe when they're at their doctor's appointment, getting a brochure, those sort of things. What do you have in your mind for the highest level exposure that this client should do? What would be the thing that if they reached that level 10 goal and they did it without rituals, so without any sort of hand washing or cleaning, because that's what this client's rituals are for this fear, what would that be for you to know, okay, they've conquered this fear, they've worked through it? Well, an 8 or 9 might be using a restroom in a hospital, but a level 10 exposure for this client should be visiting an HIV clinic, right? It should be going to the clinic, touching the doorknob, maybe shaking a few hands while you're there, taking a pamphlet or so. It shouldn't be driving by a clinic and not touching anything, although that might be a lower level, but it shouldn't be going in the clinic, not touching anything and leaving, or it shouldn't be going in the clinic and touching something, but as soon as they leave, washing their hands, throwing all their clothes in the wash and spraying everything down with Lysol that they've touched. Instead, that should be, okay, when they're ready for that exposure, they've visited the clinic, they've touched things, and they've cross-contaminated. So when they leave, they touch their face, they touch their wallet, they touch their clothes, they go to an activity with friends, and they maybe even go in their house and sit on their bed and touch their sheets before they've changed for the night or have done any washing rituals. Hopefully this makes sense of kind of how you would start to develop and what a hierarchy might look like for individuals with OCD and that developed specifically for certain fears. What's important to note is the way habituation works. So what happens is before individuals even do a ritual, right? So before they have an obsession, they might be feeling pretty good. Maybe their normal anxiety level is on a 2 out of 10 on that SUD scale, or maybe it's a 0, who knows? They're pretty relaxed. As soon as an individual is triggered, so as soon as they have that intrusive thought, they're triggered, or they're asked to do an exposure, right, which is a trigger, we see that anxiety rise. So we often can call this even anticipatory anxiety. So this might even be before they do the exposure. If they know they're having to do it, their anxiety is already at a certain level just thinking about it and knowing what they're going to have to do for the day. But let's say they didn't have a planned exposure. They still often have a trigger or something that happens that the obsession comes and their anxiety raises. So what happens is their anxiety peaks and automatically they're at a 7, 8, 6, whatever it is for that particular fear, and their anxiety is at a peak. If they do a ritual just like what's demonstrated here, their anxiety automatically drops, they feel better. So it makes sense that before clients come to us and before they understand OCD treatment, they're engaging in rituals all the time, because when your anxiety gets high, if you engage in a ritual and you feel better, what happens? You're training yourself that anytime I get an obsession and I, am triggered, I need to do this ritual to feel better. And so they keep doing it and they keep feeling better. The relief is short. It's not long, but they continue to do that because it's what makes sense and it's what works. Well, when we break that pattern and we engage in ERP with them, we're asking them to not ritualize, but instead to just sit with their anxiety. So we want individuals with OCD to say things like, maybe something bad will happen, maybe it won't. Or maybe it did, maybe it didn't. Or I don't know. We want those I don't know and those questions to come along because that's how they're going to be able to fight their OCD. At the end of the day, the main components of OCD is uncertainty, right? Individuals have this fear or this inability to live with uncertainty. And so what happens is anytime they feel uncertain about something, they want to engage in a ritual or engage in some type of OCD behavior so that they can be certain, so that they can feel better. What we know is that they can live with uncertainty, and we want to train them to be able to do that. As you see here, which is a bell curve, we know that for individuals with OCD, eventually they will habituate even without a ritual. They just probably haven't seen that yet. They're so used to the way that they feel better is by doing a ritual, that they don't understand that without a ritual, you can still feel better. You can experience normal habituation. And so what happens is this bell curve is exactly what it looks like, and that's how habituation will occur even without a ritual taking place. When we talk about OCD treatment, we'd be wrong, certainly, to talk about treatment and not talk about relapse prevention. When I talk about mental health and mental health treatment in general, I think so many individuals kind of brush over the importance of relapse prevention and having tools, strategies, schedules in place so that we can promote for individuals to keep up with the progress they've made versus relapsing. Same thing with OCD. Because we don't have a cure for the illness, instead it's about management, relapse becomes critical and so important. What we know is that with OCD, this is a lifelong management of symptoms and of a disorder, so we want individuals to be able to take the tools that they learn with us in therapy, so these exposure with response prevention tools, be able to have them in their backpack so that as they face fears, or as fears come up and as they face different struggles, they can reach in that backpack, grab the tools they need to be able to work on whatever they're going through. It's important to talk to clients with OCD about black and white thinking, right? It's not black and white. It's not all or nothing. Just because you had a bad day and you engaged in some washing rituals doesn't mean you've relapsed and now you don't have control over your OCD. Instead, that should be an indicator to yourself to say, okay, I need to make some progress, or there's some things I need to work on. What can I do right now to fight my OCD stronger, or what can I do to fight this specific fear? So maybe if you had a bad day and you engaged in a lot of washing rituals, that should be kind of a reminder to yourself that, okay, I need to set some specific exposures I need to do tomorrow and throughout the next week that are based on contamination. It's important to also talk about what is management for each individual. Often different people with OCD look at management differently. Some people who maybe struggled with 8 to 10 hours of rituals a day might think only doing 1 to 2 hours of rituals a day is wonderful management. Maybe they're able to live functionally again and they're doing well, where someone else 1 to 2 hours might have been the worst their OCD was, and that seemed impossible. So management looks different for each individual, but the end goal should always be no rituals, which also would promote for the least amount of obsessions. What we know that happens is that when we start to reduce rituals and we start to habituate properly, the obsessions come with less frequency and less power. And so in turn, we really can change the way individuals deal with obsessions, we can change the amount of obsessions individuals have, and certainly the way they respond to them. There's wonderful and lots of relapse prevention tools. So these can include worksheets, workbooks, self-help websites. I've developed a free self-help website for obsessive compulsive disorder called ocdchallenge.org. It's a wonderful website that individuals can visit that takes them through all the steps of an appropriate intervention for OCD. So it's all based on exposure with response prevention, and it also can be used as a relapse prevention model or guide. When we talk about OCD, we'd be amiss not to talk a little bit about common comorbidities. It's so important for us to really understand what our individual client is dealing with so that we can best specify the treatment that they need. So we need to talk about anxiety disorders, depressive and bipolar disorder, obsessive compulsive personality disorder, tic disorder. If we don't talk about these and understand if they're dealing with this as well, it's going to be hard for us at times to know what's the OCD and what isn't the OCD, but also where to start. If someone's dealing with comorbid PTSD, it's often important that the PTSD is addressed and managed first before we start doing ERP, because it may be way too difficult, triggering, and disturbing for the individual to engage in ERP if their PTSD isn't under control. Obsessive compulsive and related disorders are common for those with more common for those with OCD than for individuals without. There's a reported association between OCD and impulsivity disorders, including ODD. OCD prevalence for individuals with schizophrenia or schizoaffective is about 12%, much higher than the traditional 2 to 3%. And higher rates of OCD are in bipolar disorder, Tourette's disorder, and eating disorders. So again, today I'm not going to spend a lot of time speaking about BDD, but this presentation is available, so you can certainly take time to download it and go through it yourself. But BDD is now under OCD and related disorders in DSM-5. It's often where individuals are preoccupied with perceived defects or flaws, and they spend a lot of time it's very time consuming and difficult. Individuals with BDD often spend a lot of time thinking and dealing with obsessions that that there's something unattractive about them, or they might focus on a specific body area, and so they often engage in behaviors that might include covering that area up with makeup, or comparing their appearances, or asking reassurance, or touching the areas, or skin picking, etc. So as you can see, it looks like there's a lot of overlap, right? An obsession and a compulsion here, but BDD is a specific disorder that focuses on perceived defects or flaws that the individual sees in themselves. Hoarding disorder. We talked a little bit about the difference between hoarding disorder versus hoarding for OCD. Somebody who has hoarding disorder has persistent trouble getting rid of possessions. They intentionally save items and have distress at the thought of getting rid of these items. And there's a large accumulation of items. So we're talking about items that intended use of active areas is no longer available. So somebody takes over their kitchen or their living room with hoarded items that don't serve any purpose, and it should cause clinically significant impairment or distress. Trichotillomania is hair pulling, so we see individuals kind of touching and feeling hair and pulling it out. So this can happen in any region, although the areas may change with time and can happen throughout the day or during one time frame. Individuals with trichotillomania have often tried to stop multiple times, and it causes clinically significant distress or impairment. Excoriation disorder, also known as skin picking disorder, is repetitive skin picking which causes lesions. So often individuals the areas might focus on their face, arms, and hands, but they can pick from anywhere. They often might pick healthy skin or even irritated skin, but significant time is spent picking, and this can occur over months or years. They may try to hide these lesions with makeup or clothes.